in the Department of Community Medicine and School of Public Health, PJMER, Chandigarh. Second session is on personal and professional challenges of healthcare workers while providing sexual reproductive health services on women's health during COVID-19 pandemic. This session will be taken up by Dr. Neena Singla, who is a project technical faculty in the Department of Community Medicine and School of Public Health, PGI Chandigarh. And then there's a third session on COVID-19 and its impact on women's sexual and reproductive health. This session will be taken by Dr. Vimla Upadhyay, Consultant Reproductive Health, UNFPA, New Delhi. And I would also like to welcome all the panelists and the speakers. We have with us Dr. Kirti Iyengar, who's a National Program Officer in UNFPA. So all the participants, please write down your questions during the session in the chat box, and we will try to solve these sessions at the end of of all the sessions. And if need be, we can take up few of the questions in between. And you please fill up your feedback after the sessions. And once the feedback is with us, we are going to issue certificates with you. So with this, now I'm going to invite Dr. PVM Lakshmi, the Professor of Epidemiology in Department of Community Medicine and School of Public Health, PJ Chandigarh, to take her session. Welcome, Dr. Lakshmi.
Thank you, Dr. Madhu, for giving me this opportunity. So, a very good afternoon to all the panelists and the participants who are there. Most of the things I will be talking in this lecture. Lecture will be mostly the practical things. What I feel like what I usually come across when I interact with the people who come for risk assessment or the patients and all, and what the general queries are. I try to address mostly those issues so that might be of help to you whenever you are communicating with the other people. So through this presentation, I will be taking you through a little bit of global and Indian update, what is happening in the global scenario and what is happening in India current now regarding to the COVID-19 infections, and some information regarding the routes of transmission. Though everybody knows what are the various routes, but there are certain routes which people are still uncertain or discussing about. And most commonly, the important thing is regarding viral shedding and period of infectiousness, which people usually, there is a lot of importance, like especially when the people get retested of infection and they turn out to be positive. Again, then there will be a discussion like whether it's a reinfection or what exactly is it. Should we consider the patient as non-infective or not? Those queries will be looked into during this. And immunity following infection, again, like whether it is a short term or long term. And usually people come with these queries, especially someone who has done the COVID duty and tested to be positive. And again, when they are supposed to go for the COVID duty, the first question is, ma'am, are we supposed to take any precautions while dealing with the COVID patients? Or do we need to go for a testing after my duty? So these sort of things we will be I will be looking into in this. And then as a public health specialist, I want to look at what are the various measures which we are trying to emphasize on, because right now the vaccine is not available and there is no medical treatment. So what needs to be done for prevention of the COVID-19? These are the, briefly I will be touching these points during my presentation. So if we look at it at the COVID-19 scenario, like we have about 37 million cases reported from all over the world with about 1 million deaths. And in the last 24 hours, we have about 3.5 lakh cases and around 5.5 thousand deaths reported across the world. And if we look at it, like there are certain countries which have reached the peak earlier and they have come down, and like right now, the UK, France, and a few countries are seeing the second wave of infection, what they're saying, because this is a time when the winter is setting up, and especially in the northern hemisphere, and where we usually see the rise in the respiratory tract infections towards the winter, and Again, with the liftown of lockdowns and all, and intermixing with the people, opening up of the schools and everything, people see are resulting in the might be the cause of the second peak. So we are seeing a second peak in few of the countries. And coming to the Indian scenario, we have about 71 lakh cases and about 1 lakh deaths. And in the last 24 hours, we have about 68,000 cases reported and around 800 deaths reported across the country. And if we look at the Indian scenario, we have there was a continuous increase in the number of cases, and right now we are coming down. And again, there is a lot of speculations and discussions going on around whether this decrease in the number of cases which have been reported across the India, is it because of the decrease in the number of the testings, or what has led to the decrease? Is it really we have passed the peak and we are coming down? These are the recent things what are being discussed. If, as an epidemiologist, when I look at the scenario and what we are having right now, we are not having that much less number of cases. And right now, with the introduction of the antigen testing, in fact, our testing capacity across the country has suddenly picked up a lot, and right now the infections for me is more likely to be coming down, but that doesn't mean that we have crossed the peak and we are able to control the pandemic very well. The reason being, we are not into the full complete unlock till now, and when we are going for a complete unlock version, and where we will be opening up our schools, restaurants, and the domestic travel, where we will be having a lot of movement in the state buses, into state trains, and all, then we are more likely to expect increase in the cases, which we might call as a second week, but for me it appears to be, it might not be as big as what we had seen earlier, but still we might expect a second wave or a small rise in the cases in the next near future. And if we look at the routes of transmission, we all know that mostly it is a respiratory borne infection and spreads through direct contact through respiratory droplets. And again, there is indirect transmission also is through the way of mites has been reported. And aerosol transmission is being the widely debated thing, whether there is a airborne transmission is there or not and all. But if we look at it, the current evidence is pointing out that there is a possibility of airborne transmission, because they have found, especially where the patients are there, in those rooms they have found in the environment, they have found the virus is there in the air. So there can be a possibility of aerosol transmission, especially when we are in a closed and poorly ventilated environments. Especially in case of congregations, or when we are moving in a closed, they have usually reported this type of airborne transmission, especially in the aircrafts where the people are sitting for a prolonged time during the air travel in an enclosed environment. There the people have reported some sort of airborne transmission. But apart from that, in the closed environments, we hardly see any airborne transmission. Mostly, it is most of the infections right now. What we are having are mainly direct respiratory droplet infections, and a very few can be linked to the fomite transmission. And again, the people of found virus are detected in the blood, semen, stool, and and also in the ocular secretions. But how far the virus in these secretions is resulting in the transmission, or is capable of transmitting the infection, is not very certain. But definitely it is found that it may not be a bloodborne infection, which is definite. And fecal-oral transmission is one thing which recently people are looking at very closely, whether how far this fecal-oral transmission can spread the infection. So right now, if we are looking at, the evidence is very strong regarding respiratory droplets and fomites, and a little bit towards airborne transmission. But at least body fluids, the evidence is not very certain. So whenever we are looking at we know the routes of transmission. Whenever we want to interrupt the transmission of the infection, we have to attack these routes. So if it is the direct respiratory droplets, the best way is using of mask, and then again physical distancing, because respiratory droplets, they say they do not travel for more than 2 meters or 6 feet. So right now we are calling it as do gaj ki duri, especially which we are promoting. Whenever we are talking earlier, we used to say 1 meter or 3 feet, but now the evidence is saying 2 meters is better than 1 meter. And so that has been translated into the local languages as do gaj ki duri. And again, because it's a respiratory borne infection, the cough etiquettes are very, very important. And any person who is coughing or sneezing is supposed to cover his mouth while coughing or sneezing by using a tissue paper. And tissue paper should be properly disposed of in a closed lid dustbin. And again, like if there is nothing available, at least they should bend their hand, and they should be sneezing on the forearm rather than covering their mouth with the hand, which we usually try to do whenever we have a sneezing. We usually keep our hands like this, but this should be thoroughly, it should not be thoroughly discouraged, and we should promote the bended forearm for whenever we are coughing or sneezing. And again, regarding the indirect for mites, or one way, like disinfection of the frequently touched surfaces is one way in which we can look at it. And simple sodium hypochlorite solution surface cleaning is good enough, and it can kill the virus fastly in few minutes. And hand hygiene is practice which needs to be promoted, especially to prevent this from my transmission. So whenever we are talking of masks, again, there are two types of masks which we usually discuss. People say like whether we should wear medical masks or cloth masks, because especially when I'm working in the hospital setting, what I see is some of the healthcare workers, they're using cloth masks during the interaction. And when they come for the risk assessment, when we talk to them, they say we are wearing a simple cloth mask, and they were standing close to each other. And we had seen the transmission, especially among the closed groups in the classroom or at workplace when people are wearing cloth masks. So especially when you have a very large people, public dealing is there, where you in the pharmacy and all, where you come across the patients or the patient attendants coming to you, or the nursing staff or other people coming to you, it is better where you have this in the healthcare settings, it is better to wear a medical mask. And again, WHO recommends that the medical mask should be worn by all healthcare workers who are in direct or indirect contact with the patients and the caregivers of the patients and patients themselves. They're supposed to wear medical masks, and especially if they're going for aerosol generating procedures, then they should wear N95. And most of the times, the breach which is being reported in our hospital setting by the healthcare workers is not wearing a face shield or N95 mask during the aerosol generating procedures, especially if the patient has a previous negative report. So one thing which I want to emphasize, especially regarding the masks and PPE, is if we really want to cut down the risk of transmission among the healthcare workers, irrespective of the person's previous RT-PCR or antigen reporting, it is the patient can turn out whenever he is staying in the hospital for a long time, where we are not testing the attendance of the patients, where they move around and all. So it is better to consider each and every patient as a potential COVID positive patient and take all precautions, especially whenever we are doing aerosol generating procedures. And again, WHO recommends medical masks to be worn by elderly people above 60 years and people with comorbidities, irrespective of their age, where they cannot physically distance themselves from the other people. And cloth masks can be used by the rest of the general public, but whenever we are using masks, masks are not the solution for each and everything. We need to, in addition to the using of masks, practice hand hygiene, cough etiquettes, and wherever we are, we should ensure proper ventilation of the space where we are working. And the next common thing what people usually say is when we interact with the people, they usually say we got isolated ourselves as soon as we have been tested positive, as soon as we are having symptoms. But remember, the most important thing is the virus can shed even before the onset of the symptoms, at least 48 before the onset of the symptoms. And early in the stage of the illness, the viral RNA levels in the respiratory specimens are highest, and it is at the peak at the time of onset of the symptoms. Therefore, whenever we are considering the exposures, we need to take the exposure history at least 48 hours prior to the onset of symptoms. But again, if we look at it till what time the virus will be shedded in the virus and how much time it is will be infective, again, this precise interval is very uncertain. But yes, they say that but the one important thing we all should remember is prolonged virus shedding does not indicate prolonged infectiousness, especially because the method what we are using for testing is the RT-PCR, and RT-PCR detects the RNA fragments. Therefore, even if there is not a fully infectious virus particle is there inside the body, still we can get a positive RT-PCR result. And they say the viral shedding, again, it varies with the duration of the illness. For mild infections, it might you might not find like within 1 week they might become RT-PCR negative. If the severity of the illness is high, then there will be a prolonged shedding. And usually they say that if somebody has clinically recovered, after 3 days of clinical recovery, the viral loads in the respiratory specimens are very low for an infectious virus to be isolated from it. So after 3 days of clinical recovery, we see that the chances, even if he is RT-PCR positive, the chances of spreading infection is very, very low. So looking at the evidence, the current discharge criteria has been modified by the WHO in India, has followed based on this criteria for mild to moderate cases. The WHO recommends the 10 days after the onset of symptoms with additional 3 days of clinical recovery. So if somebody has symptoms for 2 days, then WHO recommends that the person should be isolated for 13 days. After 13 days of isolation, the person can mix with the other people. Whereas if the person is having symptoms for 12 days, then another 3 days after the symptom recovery, then that is 15 days he needs to be isolated. And in case of asymptomatic cases, they say that 10 days from the day of positive test result. Whereas in India, we are a little bit more stringent with our isolation criteria. So instead of additional 3 days, we add additional 7 days. So somebody who had 3 days symptoms, and we isolate that person for 17 days rather than 13 days, as per the WHO criteria. And somebody who had 14 days of symptoms and 14 days plus 3 days for discharge, because we discharge the patient only if he is symptom free for 72 hours. Plus, after the discharge, we ask the patient to stay in home isolation for 7 more additional days. So it comes to around 24 days from the onset of symptoms. Again, for asymptomatic, we have 17 days of home isolation, that is 10 days from the date of positive testing. For discharge, if he is admitted in any facility, plus 7 days of home isolation, total 17 days. So we are even more stringent on the duration of home isolation or isolation as such is very for a longer duration as compared to the WHO recommended criteria, especially in India. Therefore, after this 17 days period, the chances of spread of infection is very, very less. For most of the mild to moderate cases, they are getting discharged within 17 days. Somebody who had a prolonged illness, so their isolation period will be prolonged for that many number of days. So again, like whenever we are coming to the symptomatic infections, people say that the contribution to the pandemic is uncertain. But yes, we have a confirmed evidence that asymptomatic persons do or pre-symptomatic individuals do transmit the infection. But what percentage of the infections in the community or because of spread from asymptomatic infections are very difficult to point out at this point of time. But yes, there is a risk of transmission even by the asymptomatic patients. Therefore, the Government of India advises all asymptomatic high-risk contacts to be tested between day 5 and day 10. And if positive, they should be isolated for a period of 17 days. And again, if we look at the place where we usually get this secondary infection, most common place where the people acquire infection is the household. Though people say that the healthcare workers are at high risk, even among healthcare workers, what we are seeing is the chance of getting them infected in the healthcare setting is less as compared to them getting infected at the household. Because when the person, healthcare worker is within the healthcare setting, they are more likely to use proper PPE and hence are less likely to get infected at the workplace and more likely to get infected at the house. Yes, I am not saying that there is no infections at the workplace setting. We do get infections at the workplace settings among the healthcare workers, but the chances, if we look at the proportion of infections which happen at the healthcare settings versus the proportion of infections at the household infections are more as compared to the workplace setting. And again, indirect contact, what people usually worry about, like somebody had used we have used the same bed for sleeping during our duty time. We have worked on the same computer. But what we had seen was handling these items which were previously handled, they are at very, very low risk. And usually we have not come across this indirect contact as a common cause for secondary infection, at least in PGI among the patients who are less common was the indirect contact. And again, if we look third is environmental contamination is one of the most likely thing what people talk about, especially in healthcare settings and the households of patients. It's more likely. As this can be easily prevented and these viruses can be killed or inactivated quickly by our surface disinfectants. Any common household cleaning thing like Lysol and all that also can, even the simple detergent can kill the virus. And sodium hypochlorite is one of the best known surface disinfectant which we are using for COVID these days. And again, if we look at the risk of transmission from the animals, though this infection originally transmitted from the animals to our, but there is no major source of transmission through the animals in the ongoing epidemic. And people try to look at which are all the animals are susceptible for infection, looking at the genetic makeup, because it needs a CE2 receptor. So depending upon the receptors which are present in the humans versus other animals, how much is the genetic similarity and all, they found that the cats and dogs are susceptible animals. Among the most common, there are other animals also like mains, ferrets. But as pig and poultry are not susceptible to infection, COVID infection, therefore they are safe for consumption. So people always ask whether we can consume chicken during the COVID pandemic. Yes, it is safe to consume chicken, and especially if it is cooked, then it is even more safe. And again, the next question what people talk about is immunity. How much do I get reinfected? How long is my immunity following infection with the COVID? So if you look at the component, like what are it is the immunity which is there for COVID infection is both humoral and cell mediated, and it is a protective immunity. Humoral is the magnitude of the antibodies which you develop. It depends upon the severity of the infection. In some of the mild infections, we have seen there is a lack of neutralizing antibodies. And again, if we look at the durability of humoral immunity, it again is uncertain. At right this point, we are still learning like how much time it will be protective, and all studies are going on. And the evidence has to still to be consolidated. But it is seen that the titers decrease with the time. And then we have a cell-mediated immunity where we have CD4 T cells, which were found to be causing immune, which are causing immune response. CD4 T cells are found, and some of these CD4 T cells are found to be cross-reactive to the common cold viruses. So, how much is the influence of this cross-reactivity on the risk or severity of the COVID infection is, and if these are already present, how much will be the vaccine, what do they affect the vaccine response? Still, the evidence is accumulating and it is currently not known. And again, we have the cases of reinfection which were reported, and the risk for reinfection is very short term risk is very low. And remember, the positive RT-PCR test does not indicate a reinfection. For reinfection to be confirmed, we need to have a person with at least some sort of symptoms, and the genomic sequence of the virus during the first infection and the second infection, they should be different. Only if there is a different genomic sequence, then only we can say it can be proven as a reinfection. So even in India, there are 1 or 2 cases of reinfection reported, but they're very, very few. So, and the next thing which I will be talking about is what people usually confuse, and they mix the terms of the quarantine and isolation. Quarantine is before the onset of symptoms, when we are looking at asymptomatic individuals who had suspected exposure. Then earlier we used to quarantine the people for 28 days, because the maximum incubation period is 14 days, so we used to double the maximum incubation period. But right now, because we see that most of the people who develop infection, they develop by the day, by 95% of the 95 to 97% people, they get infected by day 7 or day 10. So therefore, we are not going to, we are reduce the period of quarantine to 14 days to disrupt the services, to minimize the disruption of the services. And again, isolation is for the people who have tested positive. This we have discussed, especially when we have discussed along with the discharge criteria. It is minimum for 17 days, and it can be more if the people are severely ill, or those who are symptomatic for more than 14 days. And again, coming to the travel, earlier we used to have lots of travel restrictions. States used to ask quarantine people or test the people, and they ask for e-permits and all. With the unlocked version, we do not have any quarantine has restrictions have been removed, and no e-permit or testing is required for the interstate travel. For international travel, till we have certain travel restrictions, they say that if somebody does not have a negative test result, they need to get tested, or they stay in the institutional quarantine for 7 days. And if somebody is traveling because for humanitarian reasons, there is some emergency at home because of death, or somebody who is seriously ill, for which the person had to go to the home, then they can write for the waiver for the embassy. And somebody who is having a negative RT-PCR report of less than 46 hours, they are being sent for home quarantine for 14 days. These are the current travel restrictions, especially related to the international travel. And some few miscellaneous points which I thought I will be touching, which I found from the Mythbusters of WHO. So mostly people, whenever you go for a park, people see like somebody is not wearing a mask, they will be having a suspicious looks and all. So WHO recommends that people, especially if they're exercising, should not wear masks, as they may reduce the ability to breathe properly. But whenever if you're not wearing a mask, you should be able to maintain this proper distance from the rest of the people. And second, prolonged use of medical mask does not make you, it can make you uncomfortable, but it does not lead to any intoxication of carbon dioxide or oxygen deficiency. So if we are using a mask, once it gets wet, we should be dispose it off and wear a new mask. And again, shoes, if you are talking, shoes cannot spread COVID-19 virus. So, it is a good practice to leave the shoes whenever we are entering the house. And again, like people are the hot and humid climates, they cannot transmit the virus, and that will kill the virus. But we have all seen that we did have an increased number of cases during the summer also. So hot and humid climates are not uh, are not like, we cannot say that they are not responsible. Transmission can occur even during these seasons, and best way is to follow all precaution measures even in all the climates and at all the times. And the UV radiation cannot you cannot disinfect your skin by UV radiation because it can damage your eyes. So the best way to disinfect your hands is by using a hand sanitizer or by soap and water. Even if the hand sanitizer is not available, simple soap and water will prevent you. And till date, there are no specific medicines to prevent or treat the coronavirus. And whatever we use, multivitamins and all, though they boost immunity, they are not the cure. And we have to emphasize that. That's all. Thank you.
So, thank you, Dr. Lakshmi. That was an excellent presentation, and thanks for making all of us aware regarding the latest changes in the Indian scenario regarding quarantine, number of days, and isolation. So, I have one burning question which we can take. Do active quarantine required for those who are high risk contacts, and for how many days? This is
High
from
risk,
Dr. Shalini Srivastava.
high risk contacts needs to be quarantined for 14 days. And they should be
Okay.
tested once, that even if they're asymptomatic between day 5 and day 10. If they test positive, then the quarantine period will be converted into isolation period for 17 days. If the person is asymptomatic, then it will be 17 days from the day of test positivity.
Okay. So thank you so much. That was one question. So with that, we end this session. There's one more from Dr. Harsh Mahajan. What is the guidelines of quarantine for healthcare workers on COVID duty?
There are no guidelines for quarantine for healthcare workers who are on duty. The current guidelines is if there is no breach in the PPE, then there is no need. If there is a reported breach in the PPE, then the risk has to be assessed, and if it is a high risk exposure, then they need to be quarantined for 14 days. But for the initial 7 days, we observe and we test them. If they test negative, then they are safe to join back to duties. But still, they are supposed to monitor for the symptoms for the next 7 days. Because whenever we are dealing with the healthcare workers, this for the other people we are saying that test 14 days, especially household contacts and all. But for healthcare workers who report high risk exposures or breach, we are testing them because we right now, especially in the COVID duties, we are facing a little bit scarcity of healthcare workers. So to have that continuous people support, we are doing it at 7 days testing.
Okay, thank you so much. So with that, I would like to invite our next panelist, Dr. Neena Singla, and because we are talking about healthcare workers, so she will be taking a session on personal and professional challenges of healthcare workers while providing healthcare services, especially sexual reproductive health services during COVID-19 pandemic. So welcome, Dr. Neena.
Ma'am, I think there is some technical issue with Dr. Neena's connection, but we have Dr. Bimla with us. Dr. Bimla, ma'am, are you there?
Yes, Kiranjit, I'm here. So should I go ahead?
Yeah. So,
Okay.
so maybe we can like after Dr. Bimla's session, we can have Dr. Neena Singh's session. So, Dr. Bimla Upadhyay is a consultant to reproductive health in UNFPA, and she'll be talking on COVID-19 and its impact on women's sexual and reproductive health. Welcome, Dr. Bimla Upadhyay.
Thank you, Dr. Madhu. I'm just sharing my screen. Give me a second. So the screen is visible, I hope.
Yes, ma'am.
So good afternoon all, and thank you Dr. Madhu and PGI Chandigarh for organizing this webinar. And the topic which I am going to discuss is what is the impact of COVID-19 on reproductive health services. Basically, I would be discussing how the services are affected, what is the actually women are facing, and what are the GOI interventions to mitigate these effects, and what is our role to ensure continuity of reproductive health services. In previous section, Dr. Lakshmi has very nicely elaborated on how the COVID scenario has evolved, and now it is the new lockdown, unlock 5, and new normal has come up. But still, there are issues at the health facilities. Women are facing many problems, and reproductive health services are being impacted. So, what are the factors that are impacting these health services? Basically, when nation-wide lockdown happened, that was one major 3 months. It was like a, major issue with the health services. The country was not prepared, and people were also like, it was a very difficult situation for everybody. Lack of transport was there. The health systems were not prepared. Closure of private facilities. Now almost most of the private facilities have opened, but services are still restricted, and we know that many of our country people, the population goes to the private system, and the private health facilities are we would say 60 to 70% of the people, they go to the private facilities, and suddenly the closure of private facilities, that too added a burden on people, and as well as the public health system. Then self-medication happened at over-the-counter medicines, but availability, and because of the lockdown, the medicines were also supply chain was impacted. Fear of contact for both the client and provider, which is still there. And at the same time, the economy, which because of the closure, the loss of job, and the migration, and now we are facing the reverse migration. And at the health facility level, the availability of services impacted the antenatal care, postnatal care, family planning services. Then because of the postponement of the elective or surgical diagnostic procedure, people were affected. The outreach work, the ASHAs and the ANMs, the field level activities were reduced. There were supply related issues, and at the same time, because young people, the youth, they were left out of the focus because of this situation. And the impact, when we see on the health of the women, on the reproductive health, the maternal, child and adolescent health, we see that because of the reduced service coverage, excess of maternal mortality and child mortality, the adverse nutritional outcomes, then there was disrupted food supply, the reduced economic activity that led to reduced access to nutritious food. Adolescent job loss happened. Then adolescent entry to the labor market was also affected, and all this led to the mental health of the women and the adolescents. Major impact happened on this population. Then disrupted education, increased school dropout, and reduced lifetime earnings. And this had impact on girls also, the early marriage and sequelae for the girls, because the vulnerable population in these situations, the women, the adolescents, the pregnant women, and because the girls especially, they become burden, and the early marriages could be may happen because of this. And this all led to impaired maternal, child and adolescent health, and nutritional and human capital is affected. So at the facility level, when we see the facilities are overwhelmed still, like we see previous presentation, 70,000 cases per day, and these mostly are like 80% are mild or moderate, but still the remaining 20%, they are the facilities are overwhelmed in treating them. And many of the cases are in the COVID containment zones, and it is estimated that because of the increased number of COVID containment zone, there is non-use of contraception because of the restriction on movement, and this may result into 70 lakh unintended pregnancies worldwide. In India, it is estimated that there would be additional and around more than 19 lakh unintended pregnancies. And there would be like 5.5 lakhs live births, 1.18 lakh abortions, and 1,425 additional maternal deaths as a result of COVID-related service disruptions that happened and the travel restrictions that happened in the period of April to September 2020. At the same time, it is seen that a modeling exercise which was done by one agency, that during lockdown, 18 lakh abortions were could not be terminated, and these were unwanted pregnancies. So this is an additional burden. Government's family planning program is also has also hit, and the hit is by around 20%. There are increased cases of gender-based violence because of the loss of job, women being more vulnerable, and there are marital discords which are happening, and this is resulting into increased risk of gender-based violence. So what are the GOIs in Government of India has done some interventions. They have tried even during the lockdown, the early after the early phase, to mitigate these effects. And one of the primary focus was the facility preparedness and the multi-sectoral spectral convergence and training of providers, facility strengthening and preparedness both for the COVID and non-COVID. Initially, non-COVID facilities and non-COVID cases were left out, but now the facilities are strengthened for both the aspects. We have COVID dedicated hospitals and other facilities which have to focus on non-COVID cases, and training of outreach workers, ASHA, ANMs, and how to maintain social distancing. They are going to the communities, they are raising awareness on social distancing and the respiratory and hand hygiene. And there have been various guidelines, various protocols for the service providers. So these are the some things which the government did at the facility level. And for the management of pregnancy during COVID-19, we had guidelines which were released first in April, then in May, and they did say about the essential services, the routine antenatal care services, and the Pradhan Mantri Surakshit Matritva Abhiyan and VHSND activities were suspended initially, but now they are working, and ANC should be provided on the walk-in basis as per the standard protocols at all at the sub-center levels, following physical distancing and ensuring the IFA calcium supplementation and tetanus toxoid to the ANC period, to the ANC women. So these were routine antenatal care services, the guidelines said. Then the high-risk pregnancy tracking and follow-up was ensured. For the intranatal services, to ensure institutional delivery, the outreach workers had to make a list of all pregnant women with expected date of delivery, ensuring the availability of the essential commodities for normal deliveries, like availability of misoprostol and disposable delivery kits for clean deliveries at home if required. So that was also ensured. Each pregnant woman was linked with appropriate health facility, and as per their antenatal status and doctor's advice, the ANMs were following them. Then district authorities also communicated with the peripheral facilities to list and make the functional list for the staff and centers where high-risk pregnancies and the women who develop complication could be shifted. Availability of the dedicated ambulances for COVID and non-COVID patients, which is still continuing, so that we have appropriate referrals and appropriate service availability for all type of women. Blood banks and the blood storage units were kept functional. And for the postpartum care, the government ensured the IFA and calcium supplementation during the PNC period, and in case of home deliveries, the ANM and the health officer, whoever was the responsible, was asked to assess the women's health and the newborn's health. Facilitate timely referral in case of any complication to a dedicated non-COVID hospital through an ambulance, which was for that purpose. For the family planning services, there was separate guideline for the containment zones and beyond the containment and green zones. all services are now available for the non the non-containment zones, and all family planning services, which include sterilization, postpartum sterilization, IUCD, PIUCD, and PPIUCD. This was ensured. But for the containment zone, depending upon the requirement and the women's accessibility, there are certain requirements to be followed for providing family planning services. The injectable similarly is available for all, and the contraceptive this comprehensive abortion services to be provided both at the containment zone and the non-containment zones, if the woman is requiring abortion, because delay in abortion could lead to other complications. So for ensuring that women are having the family planning services uninterrupted, extra packets of condom and OCPs are to be handed to the clients to avoid repeated visits, and repeat contacts are to be avoided, and continuous supply should be ensured. And what is the role of the service providers who are providing RH services? You have to protect the maternity care providers. We know that the new normal is there, everything is open, but still and the virus is not gone. Virus is in fact in present now everywhere. So we have to protect our maternity care providers and the health forces, and ensure that social distancing, the do gaj ki duri, that is very essential, and the hand and respiratory hygiene is to be prioritized for the maternal and adolescent care essential health services, but the services are to be provided to all. Uh, Care should be available to all women, but ensure that required PPE as per where the services are being given, whether it is a COVID or a non-COVID facility, personal protective equipments, the sanitation and respectful environment should be provided. Measures should be taken to protect the health, safety and security of the health providers, including prevention of violence, addressing fatigue and access to the healthcare, COVID testing and social support. Because of the COVID, the healthcare workers are very much fatigued, and their mental health is also, we see that so many among doctors also, and the paramedical staff, the nurses, everybody is affected. So we have to be very patient, and we should, as supervisor who are supervising the facilities, see that the fatigue is addressed in a proper way. Ensure that all staff follow the evidence-based clinical practices, and the women, irrespective of their COVID status, require the quality reproductive health counseling and services for all contraceptive methods, and they are given the contraceptive of their choice. Provide respectful and evidence-based antenatal and intranatal care, including postpartum contraception. So, show sensitivity towards youth and their needs, and provide right-based, youth-friendly reproductive and sexual health services. Update all staff on the GBV, gender-based violence protocols, and accordingly provide services. Then capacity building is one of the important aspects to ensure and to mitigate the impact of the COVID-19. So we have to build capacity for all cadre of providers, avoid overcrowding, and designate some services away from the higher level of the facilities to a lower level of facilities. Screening, triaging, testing, isolation, and infection prevention and control at all facilities is must. And digital health interventions, because this COVID has given a new area, which is the digitalization of everything, and the health facilities. We can also, during this pandemic, we should use the digital platforms and the mechanisms like the telemedicines, and ensure that the essential services are provided, but minimum contact wherever possible should be promoted. And self-care and administration of preventive, diagnostic and therapeutic SRH services wherever possible, like giving eye pills, contraception in excess amount to the women, which they can take care of themselves. So with this, I would like to stop here.
Thank you, Dr. Bimla, for such a informative session. We will take the questions at the end of the webinar, ma'am.
Sure.
Now, I would like to invite Dr. Neena Singla to take a session. Ma'am.
Thank you, Kiranjit. Thank you very much for inviting me. So, can I share my screen?
Yes, ma'am.
Just give me a minute.
Yes, ma'am.
Yeah, sorry for that. Can you see my screen?
Yes, ma'am. But it needs to be full screen, ma'am.
Yeah.
Dr. Neena, you can go to the slideshow and then full
Yeah,
screen.
I'm just going. I'm just going. Yeah. Is it okay now?
No, it's still, yes, now it's okay.
Yes, yes, ma'am.
Sorry for that. There was a little delay in making it full screen. So today I'm going to be talking about a very burning topic of today, that is or the present times, personal and professional challenges faced by the healthcare workers during COVID-19 pandemic. So everybody is talking about how we cure patients and how we take care of COVID-19 patients. But I think it is very important to take care of the health workers as well. So what has been the impact of COVID-19 pandemic? We have had to deal with life-threatening issues, which have reshaped the healthcare landscape. The healthcare landscape has totally changed. So in the healthcare sector, it has been globally put to the ultimate test. And this has placed a strain on all healthcare workers. Healthcare workers are the most essential resource for providing healthcare for women. So even WHO recognizing this has declared 2020 as the year of the nurse and the midwife. What is the global burden? The global burden as on 9th October 2020, as per the WHO dashboard, was 36 million more than 36 million confirmed cases all over the world, and more than 10 lakh reported deaths. And evidence suggests that healthcare workers are infected ranging from 15 to 18% and almost up to 20% in some of the countries of the total infected population of that country. So it has gone up to 20% in countries like Italy, Spain, because there the initially to start with, it was very high. So as compared to the general population, frontline healthcare workers are at an increased risk for a positive COVID-19 test. It has also been seen in studies in the UK that Black, Asian, and minority ethnic backgrounds are at a higher risk. So what is the Indian situation? In India, from 3rd of January, when the pandemic, when the first case came to India, to the 9th of October 2020, there have been 69 lakh, more than 69 lakh cases, confirmed cases of COVID-19, with 1 lakh, with more than 1 lakh deaths. And but we do not have any central data available with the health ministry on how many number of healthcare workers are affected or have died due to COVID-19. But some newspaper reports say that more than 87,000 healthcare workers have been infected with COVID-19 in just over 6 states, which had the maximum burden of COVID-19 patients, that is Maharashtra, Karnataka, Tamil Nadu, Delhi, West Bengal, and Gujarat, accounting for 3/4 of the total case burden of the country. So because of all this, such a heavy burden, the healthcare workers are put through many challenges. We have been taught from the very beginning that to give unconditional and unprejudiced service, which is the principle followed the world around by all health workers, especially in times of emergency. But as you see that healthcare workers, while performing their duty, are susceptible to various health consequences, which may be due to increased risk of infection, long working hours, increased workload, and shortage of manpower, which has become more so during this time. Then shortages of personal protective equipments, psychological stress, violence against healthcare workers, which has increased over the past few months, social and family impacts. And these have led to various challenges. So the first and foremost challenge due to increased risk of infection. Exposure to a high viral load, because they are in close proximity to the patient, they get exposed to comparatively higher viral loads. So there is a risk of more serious infection. And the most common symptoms which have been presenting are fever and cough. But many of the healthcare workers have gone down with severe pneumonia and cardiovascular complications as well. So on top of that, then they have this fear of spread of infection to family, friends, contacts, and patients. There is a guilt that they may be carrying home that infection to their family, to their near and dear ones. So quarantine, when the doctors and nurses are being quarantined, this leads to further shortage. The further shortage, in turn, it causes a vicious cycle of shortage, which leads to further stress and lowering of morale in the workforce. So quarantine and treatment then further leads to depletion of resources. So all this is causing a vicious cycle of shortage and depletion of resources and low morale in the healthcare workers. Then professional challenges faced by the healthcare workers are long duty hours, which is a major risk factor for infection, because the longer you are on duty, the more prone you are to risk of infection. And fear of contagion for themselves and the loved ones. Then the cycle of endless duties, lack of sleep, anxiety leading to errors eventually. Because if you are tired, you are fatigued, then ultimately you are apt to make the wrong decisions, and which can be fatal. So psychological problems due to high mental burden and pressure. This leads to high mental burden and pressure, lack of resources. Then there are delayed salaries, ambiguity in some tasks and roles. There is no clear-cut distinction because of shortage of manpower, people are being called to do different kinds of work. Complex ethical decision-making. And all these have led to dilemmas for healthcare workers, which may be ranging from decision-making to allocation of resources, how the different resources have to be allocated, then balancing physical and mental health needs of the workers, and at the same time caring for severely unwell patients and aligning patients' needs with that of family. So ever evolving and changing clinical guidance on patient care, because as you have seen that the guidelines are changing day by day. To start with, we had different guidelines. Now, as the disease is evolving and more information is coming out, so the guidelines are also getting changed. So they have to keep a pace with the changing clinical guidelines also. there is a high mortality rate and high degree of suffering of patients and their families. So this leads to a very traumatic experience to the doctors, because when they see so much of suffering and suffering of patients and their families, it leads to their own mental trauma. And this may sometimes cause moral injury or mental illnesses. Moral injury can lead to depression, PTSD, and suicidal tendencies. And women are reported to have increased levels of stress due to COVID-19. This is because women are working at the level of the home also and at the level of the hospital also. So they have to go home and look after their children. They have to look after their family. So they are under double stress. So you should look out for the signs of depression in any of your colleagues, which may be anger, the person cannot concentrate, there may be weight changes, sleep problems, loss of interest in daily activities, loss of energy, guilt, helplessness, or thoughts of death. You should look out for these in any of your colleagues and get them help as soon as possible. Challenges of PPE. PPE itself, it poses a challenge. There is a shortage of PPE, including masks, gloves, gowns, and respirators. Shortage of funds are there. Then many places, the single-use gear is being reused, or some local low-quality generic PPEs are being developed, which may be ineffective quick fixes and do not provide the requisite protection against infection. Then medical professionals have also reported, many reports have come from Wuhan, that they were using tape to patch up torn masks, reusing single-use eye goggles, and wrapping their toes in domestic use plastic bags to prevent infection. This is just like sending a soldier to war without bulletproof vests. So doctor has to have all these protective gear to protect himself. If the doctor is getting infected, then ultimately the patient care is going to be affected. Dryness or tightness and deformation of skin in almost 70% cases occurs. This is associated with more than 6 hours of continuous PPE use and more than 10 times per day hand hygiene. So you can imagine how a person wearing a PPE of this kind is, how they can have, how can they be comfortable? Their skin is desquamating, and even ultimately when you wash your hands time and again, the skin becomes dry and excoriated. So it is very difficult to wear a PPE for more than 6 hours. And then there have been umpteen cases of violence against healthcare workers. Earlier also the cases of violence were there, but now these have increased. The healthcare workers have to face violence and harassment from public within the hospitals and even in the community when they go for surveillance. Then people suspected of infection may violently object to screening or quarantine. People don't want to get screened or quarantined because they fear that they may be taken away and locked up. Workers have experienced assaults on their way to work as lockdowns were enforced. Many workers lost their rental contracts. People shunted out. There have been so many incidents of nurses and doctors being shunted out of their rental houses because the landlords, they feared they might get infection from the doctors. Denied access to shops or transport, or physical assault because people fear they may spread the virus. So this is one example of how misconceptions can lead to violence. This was in the case of a neurosurgeon in Chennai who died of COVID-19. His body was not allowed to be buried in the crematorium because they felt that he was the carrier of infection and it would infect everyone in the neighborhood. And there was considerable violence. They were attacked. The ambulance people were attacked. The driver was attacked. And there were several people who received injuries. So this is one of the examples how violence can ensue. Which are the most dangerous countries for health professionals? Mostly we say countries which are at war, where fighting continues despite calls for a ceasefire during the pandemic. These are the most dangerous countries for health professionals. Why? Because health centers are a soft target for the soldiers. Mostly these are bombed. You may come across so many news items of ambulances and health centers and hospitals being bombed in countries like Syria and Yemen and all the countries which are at war. So this is against international humanitarian law, but still it is going on because probably the soldiers are being treated there, and it affords a double target, the soldiers as well as the carriers. Countries like India and Mexico, known for violence towards health workers by patients, these countries are known for it. This happens even during other times, and but this has seen a sharp rise in reported incidents during the COVID-19 pandemic. Activities associated with women's health, they face a hostile reaction in many environments. What is the fundamental, which is reason underlying this is disrespect for women. This has been found that this is because of fundamental disrespect for women, and this is based on different studies. This is not just a random statement. Social and family impacts, conflict in balancing professional obligations with duty to family members. The doctor faces a lot of conflict in balancing these obligations. He has to face an unacceptable risk of infecting families because of on-job exposure, isolation from their families when they're quarantined. They face ostracization from society, and doctors and healthcare workers, they should not be turned into martyrs. They're not there to die. They are there basically to take care, but they should not be expected to die because they have not been given enough protection. Healthcare workers are overburdened without reciprocal sacrifice or recognition from society. So there is lack of administrative and political support, which is the reason for the various social and family impacts. This is a sort of comic, this came in the Lancet. So this is artist's perception of COVID workers and what they are facing. Yeah, I'll just zoom it. In this, the doctor is telling his colleague, if you realize that you signed up for 6 figures in debt, chronic sleep deprivation, 1 day off a week, and martyrdom. The healthcare workers on the outside, they say, did you see the CDC recommendations about PPE? I'm thinking about whipping out a bandana and call myself a Roma bandit. The other one says, I wouldn't mind catching a little bit of corona because the 2 weeks of quarantine will at least give me some rest because I'm so tired at the moment. Then the healthcare workers on the inside, one of them says, I want to do allergy, not contemplate my own mortality. The second one says, I'm genuinely scared. What if I get sick? Or worse, what if I bring home COVID and make the people I love sick? What are we doing? So these are the apprehensions in the case, in the doctor's minds. And this is another one. Here, the doctor is standing on a pile of bodies of doctors, and he's got nothing to fight corona with. He's just fighting corona with a catapult, and he's got no PPE. So this was an article in the Lancet. I thought it would be interesting to show it. What are the special issues in labor room? Healthcare staff working in labor and delivery units, in spite of facing shortage of PPE, spend many hours attending to multiple laboring women in close proximity and are exposed to bodily fluids. So earlier it was thought that this is not an aerosol generating procedure. So they did not need N95 respirators. But the recent research has suggested that second stage of labor should be considered an aerosol generating period, and all health workers in labor and delivery rooms should use full PPE, including N95 respirators. Provision of PPEs should be a priority in labor units, and labor and delivery units should develop special protocols for COVID-19 and low-cost innovations to protect maternal health providers. What are the recommended strategies to protect healthcare workers? First and foremost is to ensure provision of rapid, well-equipped, efficient healthcare services. And that can be done only if we protect our frontline healthcare workers, which should be a key priority, as they are the most important resource in this time. Promoting health workers' right to sufficient resources, including training and sufficient PPE for all healthcare workers. Test frontline healthcare staff as a priority. Facilities for isolation and quarantine of healthcare workers. Adequate conditions in healthcare facilities and disposal methodology must be reinforced across all clinical areas. Healthcare staff should have freedom to speak out in defense of their basic rights and the rights of their patients. So they have a right to demand that they should get the proper facilities, proper PPE, the testing should be a priority, and adequate facilities for isolation and quarantine. Involving and strengthening primary healthcare, this is very important because better access to primary healthcare services is vital to reduce violence, and better and timely communication with the aggrieved patients and their family members is the key to avoid violence. Education of the masses about the importance of prevention of infection, hand hygiene, and social distancing, and the importance of various healthcare workers in delivering healthcare programs. So if we can educate the masses about the importance of prevention of infection and hand hygiene and social distancing, to that ultimately it is going to help them only. And what is the importance of various healthcare workers? I think that would make them more tolerant. So update healthcare workers on latest knowledge and protocols to follow and help in utilization of training. Provide accurate information about the coronavirus threat level and associated health impacts in the community and place of work. Psychological supportive measures are very important because as we have already seen that the healthcare workers are undergoing a lot of mental stress and mental trauma. So they need to be supported psychologically. Psychological counseling and intervention support teams should be there. There should be various helplines for them. Shift system should be there in the hospital so that nobody is working for too long at a stretch. Online platforms for medical assistance, risk incentives should be given, and adequate breaks and time offs. Providing a place to rest and sleep when tired. Then leisure activities such as yoga, meditation, exercise, and motivational sessions should be encouraged. What the government can do? The government can cooperate in documenting, prosecuting, and preventing crimes of harassment and abuse. The Indian government has recently issued an ordinance that makes violence against healthcare workers a non-bailable offense, punishable by up to 7 years of imprisonment. Doctors and health workers must be recognized for their contributions during this difficult time. What can be the role of media? Media can play a dual role. Social media and news coverage through print and visual media like television can play a positive role by disseminating correct information and educate the public, or they can play a negative role by stoking fear and anxiety with sensational news. So they can either sensationalize the news and spread fear and anxiety, which will further lead to violence, or they can educate the masses. Arogya Setu, so that means the media has to be really responsible. Arogya Setu is the Indian government's COVID-19 contact tracing application. This can be promoted by the smartphone. This is a very important application because this helps in tracing out the contacts and telling you if you are near somebody who's COVID positive. There have been other measures for self-defense. Marshals have been posted at large central government hospitals in Delhi in their accident and emergency departments. All India Institute of Medical Sciences, New Delhi has started self-defense training among doctors for protection. This was not done now. This was done in 2017, but it is continuing because acts of violence have been going on since long. So their example should be followed. To conclude with, I would say that healthcare workers have become collateral targets in the fight against the current pandemic. Government ordinance to protect workers, it needs to be further extended and incorporated into a law and strictly enforced. Government of India is providing rupees 50 lakh insurance cover to healthcare workers and asking the manufacturers in India to do mass production of the PPEs. Telecounseling has also been helpful in limiting in-person contact with patients and reducing violence to some extent. A quarantine period of doctors and health workers will be treated as on-duty period as per Health Ministry instructions. These are some of the steps the government has taken to protect the healthcare workers and to give them security. So, we cannot afford to have low motivation and rebellion in the healthcare workforces, as it can be dangerous at this stage, especially when we are expecting a second wave and there is no vaccine in sight so far. So with that, I'll end my presentation. Thank you so much.
Thank you, Dr. Neena, for such an informative session. I think this is very important. This issue is like burning topic for like these days. And we will see, ma'am, some question. We have one question from Sushma Krishna. They are asking that, ma'am, your opinion on institutions forcing healthcare workers for COVID duty. Any labor laws to protect us? Dr.
Yeah,
Neena?
this is for me.
Yes, ma'am.
I am not aware of any labor laws to protect healthcare workers as such. But earlier it was like there were some limited duty hours the government of India had, like for senior residents and junior residents. They had made some mandatory duty hours for working, and beyond that you could not make them work. But during times of emergency, these rules can be bypassed. So as of now, I'm not really aware of what labor laws are there. This I'll have to check up and I'll get back.
Okay. Thank you, ma'am. Ma'am, we have a question for Dr. Bimla. Ma'am, are you there?
Yes, Kiranjit, I'm here.
Yes, ma'am. So, ma'am, the question is that, ma'am, with the new normal and the lockdown getting over, how can we protect ourselves and the clients visiting the healthcare facilities?
So, Kiranjit, it was very nicely explained by Dr. Lakshmi, and in some of the slides, Dr. Neena also mentioned that social distancing, enforcing that, because our population is such, and the public sector, it is overwhelmed with the clients who are visiting the hospitals. So we have to ensure that social distancing is followed, and availability of sanitizers, washing facilities, and mask by everybody. Like Dr. Lakshmi had said, medical mask for the providers, and the persons who are visiting, they should be properly, and proper mask is important to cover the nose and the mouth. That is one thing which is being observed, that people are using masks, but they are not properly using masks. So that is what I think is important to ensure within this new normal.
Okay. Thank you, ma'am. Ma'am, another question for you, ma'am, Dr. Bimla, that how must we ensure that individuals continue to get family planning services during the pandemic?
So, I discussed that the availability of services, and because of the fear, it should not be denied, because if we deny the family planning services, it will have a indirect impact on in the future. Like we may have unwanted pregnancies, abortions may increase. So, ensuring through either teleconsultations or through ASHAs, ANMs, outreach workers, where and the minimum contact possible services should be given, and postpartum and post-abortion family planning should be ensured. Proper counseling, because the women is at the facility, we should not lose. We are providing the services. We should not lose this opportunity to not give the contraception. Because this is very important, especially at this time of pandemic, where we do not want to burden the women, the family, and also the health system with repercussions of non-use of contraception.
Right. Thank you, ma'am. Thank you so much. Next question is, ma'am, Dr. Neena, for you. Ma'am, what are the helpline numbers available for healthcare workers, if you can?
Actually, if you go to the Ministry of Health and Family Welfare homepage for COVID, you'll find all the helpline numbers. But I can give you a few helpline numbers. I have a toll-free helpline number for psychosocial counseling, which is, you can note it down, 08046 11 007. Should I repeat it?
Yes,
yeah.
ma'am.
080 4611 0007. Then there is another helpline. This is a COVID helpline that was specifically for psychosocial problems for the healthcare workers, the one I have told earlier. So this one is the general helpline for COVID. This is 9111.
Yes, ma'am.
23978
Yes, ma'am.
046.
Okay, ma'am. It's
So,
911.
9111
Okay.
23978
Yes, ma'am.
046.
Okay, ma'am.
Then there is another toll-free number, which is 1075.
Okay, ma'am.
There is an email address also on the website that I have not noted down. So you can, if you need that email address, you can go to the website and find it.
Okay, ma'am. Ma'am, we have some questions in the question and answer section. I think some of them are for Dr. Lakshmi actually, but we can discuss. Ma'am, after how many days of home quarantine a person become non-infectious? Or shall we pose this to ma'am, Dr.
No,
Lakshmi?
like in her presentation only, she had said ki if it is just a suspected person who's just come in contact with somebody, so 14 days home quarantine is enough.
Okay. Okay, ma'am. And ma'am, is it compulsory to quarantine healthcare workers after COVID duty? And if it is yes, then for how many days?
For after COVID duty, now earlier it was for 14 days, but now they have made it to 7 days.
Okay, ma'am.
So, and there is one more good thing. The government has said that this will be counted as on duty period. Earlier, there was some confusion about this, whether this is going to be counted as on duty period or it will be on leave period. So now the government has said this will be counted as on duty period.
Okay, ma'am, and how long is the quarantine leave? I mean, if is it related to this only?
No, this quarantine leave, this is for this purpose. The one that if you are on duty and you are quarantined for 7 days after your duty, this is for that. But otherwise, if you are sick and you are quarantined and you are at home, then of course you'll have leave for the time period for which you are sick, for whatever time period you are sick.
Right. Okay, ma'am. And ma'am, there is another question. Then, ma'am, what is moral injury?
Yeah, moral injury is that you are the healthcare workers, they are faced with a moral and ethical dilemma because they are seeing so much of grief and so much of pain. And sometimes they have to make decisions in very short time. They have to make split-second decisions. And they are constrained by resources and by other problems, other infrastructure problems. So they are never sure about their decisions. So that can lead to a dilemma in the mind, what decision they made was right or not, and it can lead to a lot of stress.
Okay. Thank you, ma'am. And then, ma'am, just one last question: that what is the health insurance for healthcare workers in COVID?
Yeah, the health insurance for healthcare workers is by the name of Pradhan Mantri Garib Kalyan package. Pradhan Mantri Garib Kalyan package for healthcare workers in COVID-19. So under this scheme, any healthcare worker who loses his life because of COVID-19, his claimants will get 50 lakhs, or if it is an accidental loss of life indirectly due to COVID, then also the claimants will get, claimants means the people who are left behind. So they'll get rupees 50 lakhs. So earlier this was started on 25th March and it was there for only 3 months. Then it was increased for 3 months more and up to 25th September. So now it has been increased for 180 days more.
Okay. Right. Thank you, ma'am. There is actually one other question. That is, when a person is RT-PCR positive and asymptomatic, what test is required to do and when? So, ma'am, for this actually we have a session on lab diagnosis for COVID-19, which will be taken day after tomorrow. That is on 14th of October. We have a professor from Department of Virology, PGM Chandigarh, who will be taking this session on lab diagnosis for COVID-19. Registration link for the session will also be shared with you via email to all the participants, and I would motivate this registration and this webinar series with your colleagues and your friends so that maximum can benefit out of this. And please also submit us your feedback form. The link is shared in the chat box with you. And ma'am, I think that is all for today. And I would like to move on for a vote of thanks. I would like to thank Dr. Kirti Iyengar and Dr. Bimla Upadhyay from our UNFPA team for this session. And I would like to thank Dr. Madhu Gupta, the principal investigator, and she's the leader for us in these webinars. Special thanks to Dr. Neena Singla for taking such an informative session on the personal and professional challenges faced by healthcare workers. And also, I would like to extend my gratitude for Dr. Lakshmi, Dr. PVM Lakshmi. She is currently working as the frontline worker. She's dealing with COVID cases day in and day out, night and day. And it is actually very thankful for her that she took out her valuable time and gave her consent to present in this webinar. With all that, ma'am, I would like to thank you for your time, and I would like to thank all the participants for participating in this webinar. The certificates will be issued to all those who have given their feedback form. And also, please join us in the next webinar, that is on 14th of October, same time, 3 o'clock to 4:30 p.m. Registration links will be shared with you via email. Thank you, Dr. Neena.
Thank you, Kiranji. Thank you so much.
Thank you, ma'am. With this, I close this webinar. Thank you.